Hello, welcome to this next AC Forum webinar. I'm excited to have you here today. Today, we're going to be talking about rheumatic valve-associated atrial fibrillation, thinking about how we select the best anticoagulant strategy. My name is Jeff Barnes. I'm one of the AC Forum board members and webinar co-chairs. I'm also a cardiologist at the University of Michigan. And I'm grateful to be joined by my webinar co-chair and fellow AC Forum board member, Dr. Arthur Allen, who is a pharmacist at the VA Salt Lake City healthcare system. Today, we have two amazing guests who are going to help us think about this trial and what it means for us in our clinical practice. The first is Dr. Stuart Connolly, who's a professor emeritus at the Department of Medicine at McMaster University. He's also a principal investigator at the Population Health Research Institute in Canada. And we have Dr. Debbie Kwan. She's a director of cardiac MRI and a real imaging expert at the Cleveland Clinic. And so I'm really excited to have both of them share their expertise with us today. We do have important disclosures, as always, to acknowledge. These are the financial support commitments for the various presenters. And most important for this presentation would be some of the companies that make and manufacture the different anticoagulant medications. As always, we encourage you to participate in today's webinar. Please enter your questions into the Q&A box. After we get through our initial presentation, we will get to as many of those questions as possible. So we encourage you to participate by asking those questions, submit them through that Q&A link at the bottom of your screen. I want to start with a little bit of a background as to why this trial was so important to conduct. Atrial fibrillation, we all know, is such a common cardiac arrhythmia. But we also need to recognize that the reasons patients develop atrial fibrillation, the causes or the associated conditions that go along with it, really differ depending on what part of the globe you're in. If you're in one of the high-income countries like we are here in North America, Canada, and the United States, we typically see patients who develop atrial fibrillation will have hypertensive disease, they may have congestive heart failure. They often will have some sort of valvular disease, most commonly aortic stenosis. And it's very common and increasingly recognized that they'll have obstructive sleep apnea. Now, that's very different when you look at people who are in low and middle income countries, where far and away valvular disease is one of the leading associated conditions or potentially even causes of atrial fibrillation. And specifically, we see a high burden of rheumatic heart disease. And that tends to involve the mitral valve, whether it's mitral stenosis, mitral regurgitation, sometimes even in conjunction with the tricuspid valve. It could be mitral valve disease by itself, either stenosis and regurgitation together, or just regurgitation or stenosis, as you can see on the right side of the screen. But it's also important to recognize where in the globe we see rheumatic heart disease. So this image that you see here shows not only the prevalence, but also the change in incidence of rheumatic heart disease over time. So countries where there has been a decreasing prevalence of rheumatic heart disease are represented in the colors dark green, light green, and yellow. So you can see that in North America, you can see that in Russia and areas of Europe and even in Asia. However, colors represented in orange and red represent areas where we're seeing increased prevalence or incidence of this disease, especially in South America, in Africa, and in the Middle East. Now, the overall prevalence, how many people have rheumatic heart disease, is represented by the size of the dots. The bigger the dot, the more people who have rheumatic heart disease in those countries. So you can see fairly small dots in both North and South America, as well as in Europe and Australia, but much larger dots in Africa and the Middle East and even into parts of Asia. So this is really a condition most prevalent in those regions of the world. Let's give a little bit of background about what rheumatic valve disease and rheumatic heart disease is, because again, it's not something we see commonly here in North America. There's an acute form of the disease, which is often represented by some combination of pericarditis, inflammation of the pericardium around the heart, myocarditis, inflammation of the muscle of the heart, or valvulitis, an inflammation of the valves in the heart. And that tends to attack the mitral and aortic valves, leading to regurgitation. And about 10% of cases with acute rheumatic heart involvement will actually have a severe form of valve disease. This is usually caused by a group A streptococcal pharyngeal infection and is most common in younger children, the ages of 5 to 15. Now, that can then progress into a chronic form of the disease, what we call chronic valve disease, which almost always will involve the mitral valve. We saw that on that last slide. Mitral stenosis is the most common, but you can also get mitral regurgitation with this. And it's most prevalent amongst people in that 20 to 50 age range. That tends to be when it's first picked up. And it tends to be more common in women versus men. Now, one of the reasons that we're talking about it is that there is a strong association, not just between rheumatic valve disease and atrial fibrillation, but also the consequence of that. In fact, we know that patients who have rheumatic valve disease and atrial fibrillation have a higher rate of ischemic stroke than those who do not have rheumatic valve disease. You can see that on the graph on the left. Patients with rheumatic mitral stenosis, represented by that blue dotted line, have a higher incidence of stroke compared to the patients without rheumatic heart disease. And importantly, all of our studies, all of our randomized trials to date comparing a direct oral anticoagulant and atrial fibrillation excluded patients who had rheumatic valve disease or moderate to severe mitral stenosis. So we didn't have really robust prospective data to tell us about how we could manage these patients. So that was really the rationale behind this Invictus trial that we're going to be discussing today. All of our prior RCTs had previously shown that the DOACs, the direct oral anticoagulants, were preferable to our vitamin K antagonists, usually because they had similar or better stroke prevention with less bleeding. And of course, there's just the convenience of taking a pill and not having to worry about INR monitoring or dietary control. But it's also important to know that those RCTs that compared the DOAC to the vitamin K antagonist, they always excluded patients with rheumatic heart disease. So this was a population we just did not have good data for. This is a population that looks different than our typical atrial fibrillation patient. Patients who have rheumatic heart disease associated atrial fibrillation tend to be younger, they're more often female, and they have these very advanced forms of valvular disease that are less typical in our non-rheumatic heart disease AFib patients that we're used to seeing. And then lastly, less than half of patients who have rheumatic associated atrial fibrillation were being prescribed vitamin K antagonists in many observational studies. And even of those who were prescribed vitamin K antagonists, only a third were achieving INRs that were in the therapeutic range. So there was a real need to say, could we provide a more convenient and therefore perhaps more effective anticoagulation strategy? And that was the rationale behind why this trial was conducted. So this trial took patients who had rheumatic heart disease associated atrial fibrillation, and they had to have one of three other risk factors for stroke. They had to have mitral stenosis, which was a valve area of less than 2 square centimeters, or they had to have an elevated CHADS-VASc score, a CHADS-VASc score of 2 or greater, or evidence of a left atrial appendage clot seen on imaging. So one of those three things. Those patients were then randomized. Half of them got rivaroxaban, 20 milligrams once a day for patients with good renal function, dose reduced to 15 milligrams a day if they had a creatinine clearance of 15 to 49, very similar to what we've seen in our prior randomized trials with rivaroxaban. Or they were randomized to receive a vitamin K antagonist with a target INR range of 2 to 3. So a fairly familiar setup of this randomized trial to our audience here. The study outcome, the primary outcome that was set when the trial kicked off was looking at the incidence of stroke and systemic embolism. But then that protocol was amended due to some lower event rates. They added on some other thrombotic events. So in addition to stroke and systemic embolism, they also added myocardial infarction and death from a cardiovascular cause as a primary outcome of the trial. The primary safety outcome was ISTH-defined major bleeding, and all of these outcomes were independently adjudicated. Now, this was set up as a non-inferiority study, so they weren't necessarily looking for superiority first. They were looking to see if rivaroxaban could be as good as a vitamin K antagonist. And they had some statistical design where they set their hazard ratio threshold. They decided that about 4,500 patients would give them adequate power. And they had a plan to continue until they reached a little over 1,000 primary outcome events. It's important to know where the patients in this trial came from. You can see that on this global map. The countries that are colored in blue were the countries which represented enrollment sites for the trial. So there were 24 countries and 138 centers. You can see Mexico was represented from North America. There were also some involvement from South America, as well as a significant amount of involvement from Africa, as well as from Asia. Note that none of the US or none of the sites were in the US or Canada, except Canada is where this trial was run from, and that's where Stuart Connolly comes to us for today. So who were the patients in this trial? Well, we can see there were a little over 2,200 patients in each group, so this was a fairly large study. The mean age was just about 50 years old, so pretty young for an atrial fibrillation study that we're used to seeing. We had overwhelmingly female patients in this study, so about 3/4 of all patients in both groups were women. And mitral valve stenosis was highly prevalent. 85% of all patients in the trial had mitral valve stenosis. There was also a large burden of chronic congestive heart failure. More than 1/3 of all patients had heart failure in each group. There was representation of hypertension in about 1/4 of patients, with a small, very small portion of patients with diabetes, only about 6 or 7%. Somewhere around 10% of the population had a prior history of stroke, and coronary disease was not overly prevalent. In fact, there was about only 1% of patients who had known prior coronary disease. If you're used to using that CHADS-VASc score, about 40% or so of the patients had a CHADS-VASc score of 0 to 1, which meant that somewhere around 60% of patients had a score of 2 or greater. Now, how was the anticoagulant managed? And what you can see on the left side of the screen is the proportion of patients who maintained on their randomized assigned anticoagulant. So you can see in the first year, about 89% of patients were able to maintain on rivaroxaban, where 98% maintained on a vitamin K antagonist. And year over year, each of those numbers declined a little bit. We do see that there's more patients stopping rivaroxaban, but it's important to know that of the 23% who actually permanently discontinued rivaroxaban, 1/3 of them did so because they required valve surgery and then presumably were switched over to a vitamin K antagonist after they had a valve replacement. Now, for the vitamin K antagonist group, they didn't necessarily calculate the TTR the way we're used to seeing it using that Rosendahl equation, but they did report the percent of INRs that were between 2 and 3. And at baseline, it was not very good. It was only about 1/3 of all INRs were between 2 and 3. But you can see from year 1 to year 4, we see an increase in the percent of all INRs that are within that goal range, representing improving and reasonably good INR control. So here's the primary outcome. Again, this is a composite of ischemic stroke, systemic embolism, MI, and death from a vascular or unknown cause. And the rivaroxaban group is represented by the red line, whereas the vitamin K antagonist group is represented by the blue line. And as you can see here, over the first about 12 to 14 months, there's a pretty similar rate of both. And then we start to see some separation in the curve where the rivaroxaban group seems to have a higher percentage of patients who are developing a higher cumulative incidence of that composite endpoint. The hazard ratio was statistically significant at 1.25, and you can see the confidence interval there excludes 1. But it's important to note, and we're going to talk to Stuart about this a little bit, that the proportional hazards assumption, which is really critical when we think about developing these hazard ratios, was not met. And we can see that because of the way these curves are doing some crossing over. So we'll talk about what that means and how we should interpret that in a few minutes. If you look at some of the individual endpoints, the ischemic stroke endpoint is on the left and the death endpoint is on the right side of the screen. Same color distribution for rivaroxaban and vitamin K antagonists. So on the left for ischemic stroke, we actually see pretty similar incidence all the way up to about the 3-year mark. It's somewhere between 2.5 and 3 years is where you start to see some separation in those curves. Note that the hazard ratio there of 1.24 did not reach statistical significance. That confidence interval crosses 1. However, on the right side of the screen, death was slightly more prevalent. By the end of the study, it was up anywhere from 20 to 30%. And you do see a very similar curve with that splitting of the curve somewhere around 1.5 years. Hazard ratio of 1.23, and that was a statistically significant difference between rivaroxaban and the vitamin K antagonist. Now, what about the safety outcomes? What we'll see here is our first line is the major bleeding, the ISTH defined major bleeding. The overall percent per year was fairly low in both groups, 0.7 in the rivaroxaban group, 0.8 in the vitamin K antagonist group, and that was not statistically significant. You can see from both the hazard ratio and the p-value. The same is true for life-threatening and intracranial bleeds. There was a statistically significant reduction in fatal bleeding in the rivaroxaban group compared to vitamin K antagonist, but overall you can see that those rates were very low, 0.1% for rivaroxaban, 0.2% for vitamin K antagonist. So the authors' conclusions that come from the study is that in rheumatic heart disease-associated atrial fibrillation, vitamin K antagonists reduce ischemic stroke and mortality without increases in bleeding as compared to rivaroxaban. And so vitamin K antagonists should maintain as the standard of care for rheumatic heart disease-associated atrial fibrillation. And they acknowledge that the mortality benefit that was seen here probably requires further study to understand how and why that's happening. So I'd like to invite Stuart to join us and help us understand a little bit about this study. First, Stuart, I'll ask you if you have any other comments about the data that I presented, anything that needs to be corrected, and then maybe we can step through a few of these questions together.
Yeah, hi. Hello, everybody. I mean, I would say let's just go to the questions because, you know, if they'll bring all the important issues up.
Great. So, you know, we talked a little bit about the motivation for this study. You know, as somebody who is based in Canada, why was this a study you felt like was important to conduct, and how did you select sites to be a part of this?
Well, I mean, the background for this study is, as you've pointed out, the striking avoidance of studying rheumatic heart disease in all of the trials of warfarin and the NOACs that have been done over the last 25 years. You know, there may have been some rationale for excluding rheumatic heart disease patients, but it was pretty weak and it became weaker over time, and yet it continued. And clearly there was a need to sort of correct this, gap in our scientific understanding, because this is a very important disease in a large part of the world. I mean, it's essentially disappeared in North America and Western Europe, but it's a very common thing in middle and low income countries. So, and then where there would be a clear benefit from not having to monitor anticoagulation and be able to use a once a day drug. We went to Bayer, with whom we had a very good relationship, and we pitched this study to them as essentially as a humanitarian undertaking. And Bayer, to their credit, essentially funded this study as a humanitarian undertaking. There was never any real expectation that it would lead to a market approval. It was just that we needed to have this knowledge. So kudos to Bayer for supporting the study. The rationale was to correct an oversight in our research over the last 25 years into stroke prevention and atrial fibrillation.
Got it. And just for our audience who may not be familiar, Bayer is the company that manufactures rivaroxaban globally, and then in the U.S. it's Janssen that does that. So that's why Bayer is who you approach. Great.
Yes,
and when you
Bayer
thought about when you thought about enrolling these sites, how did you go about picking some of these global sites to be involved in? Was there ever a consideration for using European or North American sites, or just the incidence is so low that wasn't even a feasible thing to do?
Well, essentially, it's the old, you go to the bank because that's where the money is. If we had done this study in North America, we wouldn't have found any patients. So we went to the countries where this disease, rheumatic heart disease, and atrial fibrillation is prevalent, and those are low and middle income countries, particularly in Africa and Southeast Asia, as well as a little bit in Latin America. So this study could not have been done anywhere else and should not have been done anywhere else. Based upon the many years of work that my colleague Salim Youssef has done, we at PHRI, Population Health Research Institute, we have a very strong global presence, and we've done many studies in Africa and Asia before. So we went in many cases to our friends in these countries and invited them to participate. And we also had very strong co-leadership for the study in South Africa, where we had a strong relationship with the former head of Dean of Medicine at the Cape Town University in South Africa. Unfortunately, he passed away before the study ended, but he would have actually been the study PI had that not happened. Yeah, so we went where the patients are essentially, and we excluded North America because, I mean, we might have found a few patients. You know, if you go to Indian reservations and places like that in our countries, you will still find severe rheumatic valvular disease. In Canada, you have to pretty much go to the far north. Occasionally, you'll get an immigrant who's come in on a plane with severe rheumatic disease. We see that, you know, once or twice a year in our site, but these patients really exist elsewhere.
That's really helpful. You know, one of the things that was mentioned both when this was presented at the European Society of Cardiology meeting, it's obviously in the publication, we mentioned it here, was this point about the proportional hazards assumption and all. And I'm wondering if you could help us understand that. You know, many of us are not methodologists. What does that mean? And should that impact how we're interpreting these results or looking at, say, that graph where we do see a little bit of that overlap between the two treatment arms?
Sure. Well, we've gone from the sublime to the complex. I mean, this is a statistical issue. So our standard approach to comparing two survival curves is to use the proportional hazard modeling and log rank testing, and that approach assumes that the curves are proportional. If the proportionality assumption is slightly off, it's not a big problem. But when it's way off, when the curves are clearly not proportional like they are here, where they actually cross, then you need to employ a different statistical approach, and then the most common one is called restricted mean survival time. And so we applied both approaches because people would be familiar with the other, but the correct approach and the approach we used for our final statistical analysis was restricted mean survival time. As it turns out, they both give the same results. So it isn't a big problem, really, in terms of interpreting the results. And it's technically correct to use the RMST, which is what we did. I don't think there's a whole lot more to say here. It's just something you should know about if you're interested in clinical trial interpretation. Keep it in the back of your mind.
Great. So we can still look at those curves and understand as they separate that that's meaningful, but from a statistical standpoint and looking for those p-values and things, that there's nuance in exactly which ones we might look for.
Yeah, we actually applied the p-values to the RMST data, but at the end of the day, it doesn't affect our interpretation of the results. What affects our interpretation is, why did the curves cross? That's a more interesting question. And maybe we want to get into that. I think your listeners will be very interested in why we think the curves crossed, at least why I think. There's a lot of uncertainty there and some debate, but I can give you my opinion.
Yeah, no, I think that's going to be a great question. And maybe I'll hold on that for just a minute and we'll come back to it, because that's really going to be interesting. You know, the last question that I've been hearing a lot from folks since this was published is, what does this mean for us in North America? And I'm curious to know, as you're talking to your colleagues in Canada, or as you sort of talk to many of us who are based in the US, how does this trial, or does this trial, impact the way you think about managing patients who have atrial fibrillation and maybe have some degree of valve disease? Does this play in, or is this really something for patients who are in other parts of the world?
Well, I think the basic message, I mean, there's certain nuances perhaps we can get into, but let's go to the basic message, which is no. And we don't see these patients in North America, or we see them only very rarely. And when we do see them, the current guidance is to use warfarin, right? Because they were not involved in the other trials, and all of the guidelines say if you have rheumatic valvular heart disease, and specifically mitral stenosis, then you should use warfarin. So first of all, it doesn't change guidelines either in North America or anywhere else, because the guidelines already specified warfarin. So that's simple. And secondly, it really doesn't change anything about our management of patients who have some valvular disease that's not rheumatic. And why do I say that? It's because there were a lot of those types of patients enrolled in the NOAC trials and in the warfarin trials. Patients, say, with mild to moderate mitral valve disease or some degree of aortic stenosis, even some patients with bioprosthetic valves were enrolled in these studies. So I don't think it changes anything for our current practice, in terms of the big picture. I think one thing I think it doesn't do is reduce our interest in using rivaroxaban. I don't think this trial tells us some harm that rivaroxaban is causing. What it's telling us is that there's something about warfarin in these specific patients that is actually more beneficial than we thought, and it isn't actually related to stroke reduction. It appears to be an effect on mortality that's rather distinct from any effects on stroke, which we can get into if you want to discuss more.
No, that is really great. And we're already getting some questions from the audience about sort of why these curves diverge, what could potentially get to it. So we'll ask those questions in a minute, but you brought up a really great point, and I want to invite Debbie Kwan to join us as our other panelist here, because you talked about the importance of recognizing what is rheumatic valve disease versus what are the many other forms of valve disease, really more common here in North America. And Debbie, I'm wondering if you could help us understand, many of us will see patients who have gotten, say, an echo, and somebody's commented on a rheumatic appearing mitral valve. I'm going to play this clip here just so people can see it. Can you just walk us through a little bit? What are we seeing? What leads somebody to make that description? And what does that really mean as somebody who's sort of a cardiac imaging expert?
Sure. Yeah, this is a really fantastic trial. And again, major congratulations to Stuart and his team to address this really important question that has been plaguing many of us imagers who take care of patients with this with valve disease. So in this particular echo, you can see that anterior mitral leaflet has what we call a hockey stick appearance. So when the valve opens, you can see that it takes this kind of a reverse L shape form. We call that doming. That's very abnormal motion for a mitral valve to take when it's opening, and that's actually pretty characteristic or pathognomonic for rheumatic mitral disease. We hardly ever see this in any other disease entity. In the North America, when we see mitral stenosis, most of the time it's because of calcific disease. So a lot of the time you'll see a lot of big chunks of calcium in the annulus that sometimes also encroaches into the mitral valve space. And that causes restricted opening and also mitral regurgitation, but it almost never causes that kind of hockey stick appearance when it's opening. So that's usually what we're referring to when we say rheumatic appearing mitral valve, is that hockey stick doming appearance. And it's also important to make sure that you see it in more than one view, because depending on how the sonographer is acquiring the images, sometimes you can artifactually create an image that can look like that, but we often will say you have to see in two different orthogonal views to be able to say with more confidence that this is an actual true finding.
That's really helpful to understand sort of what you're seeing. So I'm wondering if you're doing these echoes and you're reading this, if you're making a comment on an image like this, do you have a sense for like how often does that represent true rheumatic heart disease? And therefore, would you apply sort of the Invictus trial results to that patient? Or is there some difference between the clinical disease and the imaging? How do you think about the sort of the predictive nature of this image and what we should think of when we read a report that says rheumatic appearing mitral stenosis?
Yeah, those are very important questions. When we see this by echo, we don't go further to validate that this is rheumatic heart disease. We may ask in the clinic, did you ever have strep throat, or have you been never told that you had rheumatic fever as a child? And many times the patient doesn't remember, because all of us have had sore throats and we don't necessarily get strep testing or ASO titers or whatnot. And we actually don't really check antibodies in these patients because, it's kind of a non-specific thing. So because many of us have been exposed to strep, doesn't necessarily equate that you then therefore have mitral rheumatic disease. So really, we just go based on the echo findings. And so for me clinically, when I see that kind of mitral appearing valve, I just assume, therefore, then it's most likely rheumatic disease. And then I would apply, now based on the Invictus trial, I would make sure if they have atrial fibrillation that I would put them on Coumadin rather than any of these other DOACs. So we don't necessarily go further. Wanted to ask Stuart, when you were doing the inclusion criteria, I think when I was reading the trial that it was really just based on echo criteria. Is that correct? Or did you do additional testing or validation to ensure that it was rheumatic valvular disease?
No, it's echo. They had to have a echo features of rheumatic disease, which you've described and which are pretty pathognomonic and clear. And the investigators that we worked with see a lot of rheumatic disease, so they know these criteria very well. These patients all had rheumatic disease, virtually 100%.
Yeah.
Based on findings of the mitral valve. They also had other valve disease, right? Some of them had rheumatic disease that did not involve severe mitral stenosis, but they would have had changes in the mitral valve that would have been pathognomonic, and then they might have had severe aortic disease.
Yeah, that's a good point. Rheumatic heart disease, the most common valve that's affected is the mitral valve, but obviously can affect the aortic valve and the tricuspid valve on top of that. But quite honestly, by echo, the most characteristic findings for rheumatic heart disease are the mitral findings. The aortic findings, you can see thickening, but that can be non-specific, especially as the patients get older. But obviously, if you have a younger patient with thickening, then that's somewhat abnormal. And that in a third world country, that first thing you would think about, obviously, would be rheumatic heart disease.
Yeah, just a bigger comment. That so for most people listening to this session, I mean, you're going to have an echo report. If there's rheumatic features, it'll be mentioned by in the echo report. I would expect, certainly in Canada it would, and that's what you would look for. You don't need to read the echo yourself or ask specifically. I mean, if you don't see someone say, mitral valve disease consistent with rheumatic or whatever, then you're fine. That's not rheumatic, I would assume.
Yeah, I think that's helpful to understand. And again, overwhelmingly, the majority of mitral valve disease in North America is degenerative or calcific, things like that, which was not the group in this study. I know we're getting a, go ahead.
I just want to make one comment. If we're talking, obviously our audience is mostly a North American audience. One thing that I will want to say that I definitely agree that most echo reporters would comment on this, but in the off chance that you get a report that doesn't necessarily say that, but there is some evidence of mitral disease because there's mitral stenosis or whatnot. One other clue is if your patient is young. So if they're 50 years or younger and they have mitral stenosis, that's very abnormal because in North America, most of it's like degenerative disease over time. So if for aortic valves, you would think bicuspid aortic valve, but if they don't have a bicuspid valve and they're younger, they're 50 years or younger and they have aortic disease or mitral valve disease, then you should maybe think, oh, well, maybe was there rheumatic appearing things on the echo that just wasn't reported. And then you can go and ask the person who read the report to maybe consider that, and they could give you feedback. But that's just one other thing to think about, is you could use the age as another qualifier.
Yeah,
I think that's so important.
The one other qualifier would be, did they grow up in Bangladesh?
Yeah.
Or did they grow up on an Indian reservation in North America? If not, they probably don't have rheumatic disease, because it's super rare if you're born in North America.
Yeah, really looking at that whole person is so important as we think about how best to treat them. This has been a great discussion. We're getting a lot of questions from our audience, and I want to encourage folks to keep doing that. I want to invite Arthur Allen to join us because I know he's been going through some of the questions here. And let's see if we can get some more input from questions from the audience and ask those of Stuart and Debbie.
Thank you again. Excellent presentation, Jeff, and a very important study. I think, bottom line, and we've kind of glossed around this, but I think that we kind of need black and white for our audience. We're talking about rheumatic heart disease. What we see in the U.S. Is usually not that, but there is this question of what do we do with non-rheumatic moderate to severe mitral stenosis? And should we either lump those in the same category as this trial, or still favor warfarin just because of prior trial limitations and prior definitions of valvular, non-valvular AFib?
Well, I'll take a go at that because I think the answer is pretty clear. So there was lots of that type of patient enrolled in the NOAC trials, and each of those studies has reported on those patients as a specific subgroup. And then now there are meta-analyses that have combined all of the data from all of these trials. And the answer is pretty clear that the benefits with rivaroxaban, apixaban, and edoxaban that we're seeing overall apply to these patients with mild to moderate valvular heart disease of various types. So I think it is clearly been, I think the result is clear.
What about, again, that moderate to severe mitral stenosis category, which has been kind of where oftentimes we're dealing with pharmacists who are going by, non-formulary criteria and those kind of things, which are driven by trial limitations and PI. Jeff, maybe you can say as a practicing, cardiologist that has to navigate this as well. What are your thoughts on those issues? Is it something we really need to even be looking for or ask?
I think it's a really good question. It's a hard question to answer. And I certainly don't think that the Invictus trial immediately applies, right? I don't think that simply because in a rheumatic heart disease population, we saw this difference for warfarin over a DOAC means that all patients with moderate to severe valve disease cannot get it. But I do have a fairly frank conversation with my patients to say, look, the data is not clear cut. And the safest thing may be to go with a vitamin K antagonist like warfarin. We have decades of experience. But some of my patients are very motivated to say, I don't want to have to deal with the INRs. I don't want to have to deal with the dietary restrictions or whatever else. And in those patients, I will offer them a DOAC, whether it's rivaroxaban or apixaban, because those are the two we use most often here in the US, as long as they're aware that the data is just more limited in that population and that I can't tell them with as much certainty as I could for a patient who has either mild valve disease or no valve disease. So that's the way I practice. I don't know, Stuart or Debbie, if you guys have a different take on that more severe mitral stenosis AFib patient.
I think you point out that this is a place where you could have various opinions and there's no right answer. One other point just to keep in mind in your discussion with the patient would be that we saw there was a slight excess of bleeding with warfarin. It wasn't very much, but that in part was because the age of the patients in our study was a mean age of 50. And, we know bleeding is with anticoagulants goes up with age rather strongly once you hit the 70s. So, I think the age of the patient might be a factor here as well. And so maybe the younger patients, you stick with warfarin. And as Deborah points out, that means that they're more likely perhaps to have actually been rheumatic, whereas with older patients, not so much. I think valve severity is very important too. I mean, the patients who seem to get the benefit from warfarin in our study tended to be patients who were, had fairly high risk of dying because of their very severe valve disease. So that's another thing to put in the equation.
Yeah, so coming from a perspective of someone who does transesophageal echo and looks at these patients with moderate to severe mitral stenosis, there's almost always smoke there. So having mitral stenosis causes a lot of stasis of flow in the atrium and makes them higher risk for clot formation on top of having atrial fibrillation. So definitely these are higher risk individuals, but I go about it the same way that Jeff has said, because most patients don't want to go on Coumadin. They really don't like having their blood drawn frequently and then having to adjust, and they don't like having to stop their or adjust their diet and whatnot. So sometimes it can be, there is a preference for patients to go on, these other agents. So I think just having an informed discussion with the patient and having them be aware. And obviously, and then the other question is if they do have a left atrial appendage thrombus, then does that also change your management strategy? And that becomes even more stickier because, those are difficult questions. But yeah, very, very pertinent because we see this quite often.
Yeah, Debbie, you're getting exactly to kind of where I wanted to go next, which is, again, trying to keep it super practical. There are times when we get some data, from primary studies or even from guideline documents where we have, a preference for one agent over another. And so at some point you have this threshold of doing this rises to the level of malpractice, right?
Mhm.
And then you have these other situations where shared decision-making is reasonable. Okay.
Mhm.
So 2 patients, one moderate to severe mitral stenosis, non-rheumatic. The other patient moved here from Bangladesh, rheumatic mitral stenosis, no fooling. Both patients, you try warfarin, it's a nightmare, or they just right out of the gate say, you can't make me. It's trying to deal with INRs and INR monitoring. Both cases reasonable for shared decision-making? Or in the rheumatic valvular patient, does this rise to the level of, sorry, Charlie, warfarin it is?
The latter. If it's a clear-cut rheumatic, I think that you really need to treat them with warfarin and figure out a way to get control.
Okay, that's I think very important for our audience, which is, again, a large proportion of pharmacists in this group, and I think that's very important to know where to draw those lines. Thank you. Going to Stuart, I would like to ask about your thoughts on the potential benefits of warfarin and why the curves separated after a few years. And as part of that, I'd like to speak to the poor, first of all, Rosendahl wasn't used, but we had this poor kind of INR control, I would arguably say, for the first 2 years of the trial. And then which seems to align, is that related? We had a lot of transition from rivaroxaban, a lot of it for valve replacement, despite exclusion criteria trying to avoid that. Can you speak to all of that and how that comes together in your mind?
No, there's a few issues to unpack there, but all great points. Well, let's just talk about INR control. So when we looked at INR control of the 50% of patients who came into the trial on warfarin, it was rather poor, and that's not rare in these countries to have pretty bad INR control. And we saw that as a problem for the generalizability and interpretability of the results. So we went out of our way to try and improve INR control, and we basically preached a very, very, very simple approach because we just didn't want to make things complicated. People couldn't get fancy programs like Dawn to do this. And we preached a simple approach. If it's below 2, you raise the dose by 10%. If it's 2 to 3, you don't touch. And if it's above 3, you lower the dose by 10%. And don't do anything else, please. And use weekly dosing. And that simple message we just hammered and hammered, and it had an effect, I believe. I mean, things got better rather quickly. So I think you exaggerate when you say 2 or 3 years. By the end of the first year, we were actually getting INR control up into the 60% range, which is not bad, really. It's not like 70 or 80 that you might get, but it was pretty good. And it was so. I also think, and we have some other evidence that we haven't published yet, to suggest that the curves crossed because the INR control got better. I mean, the improvement in INR control coincides temporally with the crossing of the curves. So it suggests that it's causal, but it doesn't prove it. There could be other factors going on, but it does look like that could be, that's an important part. So the INR control was clearly a factor. We were able to improve INR control by preaching a really simple algorithm. And yeah, we didn't use Rosendahl because I'm not a great believer in Rosendahl. I mean, if you don't have every INR, it becomes a problem. And in fact, getting the mean INR at every follow-up visit is a very good surrogate for what you might get from Rosendahl. So we think that the INR control measurements are pretty good in our study. Did I answer all those questions? I think I got most of them.
Well, the only other question was the interesting fallout of how many patients transitioned from rivaroxaban, despite trying to exclude patients who might undergo valve replacement.
Well, we knew we couldn't completely exclude them because, I mean, by the time you get atrial fibrillation in rheumatic heart disease, you've actually got pretty advanced disease because they tend to get this relatively young. And so we came up with a policy that if the surgery wasn't scheduled or planned to occur in the next, I forgot what it was, 6 months or a year, But obviously we had some surgery, and when they had surgery, they almost always got a mechanical valve because they were young, and then they had to transition. And then there's some other, loss of patients switching off of Riva that we don't really understand. It also happened. But just to, reassure you that this result is not due to people coming off their Riva. Most people who came off Riva did go on warfarin. So it's not like they went on an inferior anticoagulant. They went on the better one, as it turned out, in the long run. And even when we do the analysis as a non-treatment analysis, so we basically exclude any events that occurred after either drug was stopped in both arms, the results are essentially identical. So the results has nothing to do with coming off Riva. And the fact that they came off Riva does not, I think, make this study hard to interpret.
Stuart, can I follow up? I'm curious to know, you obviously pointed out that association between the INR control and the sort of divergence in those curves, which I thought was really striking. Do you think there's anything about warfarin itself? Like, does it have some property that's particularly beneficial in a rheumatic valve disease patient that, do we need to explore that more in other populations? Or, obviously you're guessing here. Why do you think there was all this benefit?
Well, you've raised a question that I find perhaps the most interesting part about the whole study. There is no clear answer. So let's start off with saying, okay, you've raised the question, why did we see such a benefit from warfarin, especially when we consider that really this is probably not a hazard of Riva. This is something about warfarin that we didn't know. And what is it? Why do I say it's not a hazard of rivaroxaban? Well, rivaroxaban has been studied in many, many other heart conditions and in many other patients with various forms of heart disease, including AFib, and has never shown a hazard in terms of mortality. If anything, there's a trend towards benefit. So this is not a hazard of warfarin, Riva. What is warfarin actually doing in these patients? Well, there are some clues. First of all, although there was a tendency to a reduction in stroke, the difference is relatively small. And if you look at the cause of death in these patients, a very, very tiny fraction of them were actually deaths due to stroke. Almost all of the benefit was in the prevention of cardiovascular death, either sudden death or pump failure death. So it seems to be doing something to the myocardium, if you want to take that as your clue. What it's actually doing, is it preventing some fibrosis, or exactly what is not clear at all, but it does seem to be real. I mean, the p-values are extreme on the cardiovascular death. There's a ton of data. We had 1,000 deaths in the study, almost 1,000. So it's not like a sort of a chance finding that might not be reproducible, I don't think. And it certainly, as we said in the paper, it deserves further study. And it's a delayed effect, and
it was interesting.
Maybe you need to treat with warfarin for 4 years to start to see it. There is actually, just to point out, there's another study of warfarin in patients with bad heart failure. It was called WARSIF. It's published about a decade ago. It compared warfarin to aspirin or clopidogrel in patients with aspirin, I think, in patients with systolic dysfunction heart failure, or HFrEF as we call it. And basically the trial was reported as negative, but they also reported that in year 1 it was negative, in year 2 not so much, in year 3 it starts to show a benefit, and by year 4 it's statistically significant benefit. And so it's a somewhat similar result to what we got here with warfarin, showing a delayed effect. Why their effect was delayed is not clear. You have 2 trials with the delayed effect benefit of warfarin, where the effect is mostly in preventing death from heart failure. So interesting.
Yeah, all the more reason that our anticoagulation clinic staff need to work so hard to help our patients maintain on their anticoagulants, so that they can start to realize if there is a delayed effect after several years, that they're able to safely stay on those anticoagulants long term when it's indicated.
Yeah. I think it's important also for us to think, when we think about older trials like Watch and WARSIF, we weren't very good at managing warfarin back then, right? And so when we're thinking about trials that said anything about warfarin, the truth is we were actually comparing to not terribly well managed warfarin, and that needs to be taken into consideration when evaluating older trials. So.
Debbie, I wanted to ask you a question. You know, this study came out, and I've heard a lot of people, you know, in the anticoagulation world sort of talking about what does this mean. I'm curious for you and your colleagues who are imagers, is this trial at all changing sort of how routinely you're looking for those rheumatic changes in the valve, or how you're thinking about what it means when you call that out because of the downstream effects? Or is this something that really any hospital in America, people are going to look at this and report it, and it's not really, the standard is not changing? I'm just curious what conversations you've heard amongst your colleagues.
Yeah, sure. Well, I mean, as Stuart had pointed out, this is very rare. So at least in North America, so we don't see that many patients who have these kind of characteristic findings. But in our cardiology fellowship, it's always on the boards. We've been very well trained to look for this kind of pathognomonic findings. So when we see it, we actually most of us get excited. I'm like, oh my gosh, this is rheumatic heart disease. We would be reporting it. So I don't think it's really changing how we are necessarily reporting our echoes. I think most places would be very tuned to being able to recognize these changes.
That's helpful. Thanks.
I want to talk about one more kind of specific situation. If you think about how the guide, first of all, one thing that we need to orient to is that valvular AFib was, the definitions varied across the different DOAC trials. There was no early on, there was no really early you know, kind of like congruence of what that even meant in guideline statements. That kind of settled a bit. But one of the things, there was a guideline document that had this kind of like gray area where it said, well, if a bioprosthetic valve was put in place because of mitral rheumatic valvular disease, there was this kind of like caution favoring not using a DOAC and favoring warfarin in that setting. Based on the results of this trial and what we know about what happens when we fix these valves, I'm curious to know, you know, Stuart and Debbie, your thoughts on that.
You know, it's hard to know. There's no right answer.
I'll tell you, at our Cleveland Clinic practice, I think that most patients, usually in the immediate postoperative setting, when they're put on anticoagulation, there's a strong predilection to be putting patients on warfarin, regardless if it's previously a rheumatic valve versus, you know, just degenerative disease. And I think some of that is because the thought is that if there's bleeding after surgery, that there's more comfort in terms of reversing the anticoagulation when it's Coumadin with vitamin K and you know, FFP or whatever. So at least here, that's kind of our preference. But in the long term, when a patient has a bioprosthetic mitral valve, for instance, if it was degenerative disease, I think if the patient has a strong predilection to being on a DOAC rivaroxaban or apixaban or any of these things, I don't think we are saying no, because there's not really definitive evidence from that standpoint. But I think for me, with this Invictus trial and this discussion, if they previously had rheumatic disease and we replaced their valve, and now later they develop atrial fibrillation, I don't know, there could still be underlying things that predispose them, whether it's to stroke or something in the myocardial substrate. Maybe there's microvascular dysfunction or something that I probably would lean towards putting them on Coumadin. But again, there's no definite guidelines or data to say after the valve is replaced, will we still see these things?
Thank you so much. Back to Liz.
Thank you all so much. Dr. Stuart Connolly, congratulations on this important research, and thank you so much for sharing your expertise with the AC Forum membership today. Dr. Debbie Kwan, thank you for adding your practical experience and expertise in valve disease, really helpful to all of us. And to our amazing AC Forum board members, Dr. Jeff Barnes, thank you for your very clear and thoughtful presentation and expert facilitation as always. And last but never least, Dr. Arthur Allen, thank you for your excellent moderating and for being our practical pharmacist voice. I also want to thank our wonderful behind the scenes staff member, Amanda Katz, who's going on maternity leave tomorrow. Thank you for hanging in with us through this webinar. As always, this webinar has been recorded, and Amanda's last task will be to post this on the AC Forum website, which will go live next week. A few quick announcements. I want to let you know about a tremendous new rapid resource on drug-drug interactions. Since interactions are constantly changing, this updated resource will help you learn how to always stay up to date on this important area. Thank you to Drs. Sarah Vasquez, Ryan Fleming, and Craig Beavers for their strong work. I also want to remind everyone, oops, sorry, that opened up. There we go. That registration is open for our in-person national conference in April 2023 in San Francisco. Early bird registration deadline is November 30th, so please register soon to get the best price. We have multiple award and scholarship opportunities to support the ongoing education for clinicians from underrepresented racial and ethnic groups. The awards include free registration, and a $1,000 travel stipend. But the deadline is fast approaching, so please visit our conference website, which is no longer on the screen, but it is acforum.org/2023 to learn more. And lastly, I'd like to thank our corporate sponsors who help support this webinar program. Thank you very much for sharing this hour with us, and enjoy the rest of your day.